Hello everyone, this is Dr. Meera Kumar. Welcome to the Part 3 Summit. We have a 32-year-old woman. She is 20 weeks pregnant, has been diagnosed with breast cancer. She is terrified. She is worried about her baby. She is worried about dying. And she is looking to you for answers. Yes, we have the Pregnancy Associated Breast Cancer Station. This is a station where candidates often focus heavily on clinical facts they may or may not know and forget what the examiner is really looking for. The communication aspect, empathy, shared decision making, and patient safety. Let's walk through how we can approach this consultation in the examination. Now, initially, the best way to open the station is by confirming the patient's name and identity and address them formally. These kind of emotionally charged stations, it is better to address the role player in a formal way. Don't be concerned whether you will be scoring on the rapport building front by not sticking to the first name basis. Trust me, this is the best way to do it in such emotionally charged stations. You can be empathetic by assuring her what exactly is happening, acknowledging her concerns. That is how you score rather than by calling her on the first name basis. So establish her concern. Give an open question. What exactly is the concern? Tell her that you can only imagine how difficult this must be for her, and tell her that you are sorry you are meeting her under such circumstances, and rule out any acute concerns at that point of time, whether she is in pain, any concerns to be addressed immediately. And let her give the story and ask her what is the biggest worry at that point of time. These will be the key information gathering points. What are the main concerns? Understanding of the diagnosis, whether she knows about the status so far, which is why you need to give an open question initially. Remember, this is not a BBN station. The candidate information clearly states that the MDT discussion has taken place and she is here to go on with the obstetrician visit. So you need not go about the BBN, but at the same time, elicit her understanding of what has been happening so far. This is one of the most important history to elicit, which is the background information, what she already knew. Once you have elicited that, ask about her biggest worries. What is her plan for the pregnancy? What are the concerns around the chemotherapy? What are the concerns around delivery, about breastfeeding, her future fertility, her support, emotional well-being? Also, make sure you mention the points related to the safety like BMI, because this is important in the VT risk assessment, because she is a patient with cancer and BMI, if it is high, puts her at a higher risk for venous thromboembolism. So make sure you address the basic information gathering. Following that, you go on to the key explanation, what is important for the station. So her questions, whether she needs to continue her pregnancy, whether terminating the pregnancy is necessary, because she might be thinking pregnancy might worsen the prognosis of cancer. And what will happen if she is receiving chemotherapy? What are the possible effects of chemotherapy on her baby? And what will happen to her pregnancy? What will happen to her delivery? So these are all her concerns. So start the explanation with involving the disciplines, the multidisciplinary team that you're going to involve. The breast surgeon, consultant-led care for her pregnancy. The oncology team will be continuously throughout the care. The breast cancer nurse, Macmillan nurse. Also with the perinatal mental health team, because this is a difficult time for her around the time of pregnancy. And keep the GP in the loop. Involve the neonatologist also, because there is a risk of low birth weight, and there is a risk of preterm birth, and there is a risk of fetal growth restriction. And because she is diagnosed with cancer at an earlier age, and she has another girl child, it's imperative that whether genetic counseling has been done and involvement of geneticists needs to be mentioned here as part of information that should be shared with the colleagues. Following this, you will be looking at what exactly she needs to know. She needs to know that pregnancy as such is not going to impact the cancer. The evidence so far says that the pregnancy is not going to make the cancer worse. And chemotherapy is another concern which she has. whether she can take the chemotherapy during pregnancy. You need to tell her that because she is over 14 weeks of gestation, she can take the medications. The risk of the medications affecting the baby's development is very low. So it's safer to be taken in the second and third trimesters of pregnancy. The risks as such due to the medications could be as for any non-pregnant woman, the adverse effects and the red flags which she needs to look out for, the neutropenic safety crisis, right? The infection fever, this she needs to know. So as such, the chemotherapy can be safely given. Only that this is going to be stopped around the time of delivery, 2 to 3 weeks prior to the delivery. And following the delivery, if needed, as per the expert's opinion, it might be restarted. And she also needs to know that while she is on chemotherapy, unfortunately, breastfeeding is not possible. But it will be decided at that time based on how she has fared so far. So give her this information regarding pregnancy and the breast cancer. And tell her that termination as such for the pregnancy as such is not going to improve the survival with regards to the breast cancer. But if she wants to terminate the pregnancy, this is going to be her decision and she will be supported. So she needs to understand the background of why termination might not be necessary. But still, if she wants to terminate, she can go ahead and terminate the pregnancy. You are going to support her decision as well. So once this information is given, go on with what further care you are going to give for the pregnancy. This will be a consultant-led care, joint or oncology and obstetric care. And because of the risks which we have mentioned, you will be offered serial growth scans and routine pregnancy visits, mental health support, and you will be offered medications which are safe to be taken during pregnancy, which can arise due to the chemotherapy. Right? So those medications which are safer to be taken for vomiting, sickness, fever, those medications will be given to her and continuous support will be offered to her. And if she has any of the safety concerns like red flags, infection, fever, feeling unwell, flu-like symptoms, sore throat, anything at all, you would need to be coming to us immediately. We'll offer you 24/7 contact number. And throughout your pregnancy, delivery, and after delivery timing, you'll be assessed for risk of clot formation and we'll be managing you accordingly. Right? So this needs to be mentioned. And one of the most important points you should not miss is that there should not be any delay in the treatment. Okay, so this needs to be mentioned. And finally, she also needs to know whether she can have future pregnancies. Here she wanted a large family. So you need to tell her that stage 2 cancer has been called as a treatable cancer. So the prognosis as such currently is generally good. So there is nothing which points that this is not possible. Okay, a large family, there is nothing which points that it is not possible. But you would need to be on the continuous monitoring along with the oncology team, and you'll be offered safer contraception following your delivery, which will avoid the hormones. And once you are cancer free and the cancer doesn't come back in the time where the risk is going to be high, like the immediate 2 years following the cancer diagnosis. And once the oncology team has given a go, you can go on to plan for future pregnancies as well. But we will be discussing this later on. Right? So this you need to mention her. And she might have some questions regarding the mode of delivery. You can tell her that as such, the breast cancer is not an indication for a cesarean section. We can plan for delivery vaginally, and the timing also can be at term after 37 weeks if nothing else is pointing towards a need for an earlier delivery. But because she is on chemotherapy, there is a risk that the delivery can start earlier. So you would be offered delivery in the hospital along with the team and one-to-one midwife care and pain relief options, and neonatologist who is going to be taking care of the baby will be present. So this needs to be mentioned. Following that, ask her whether further questions she has, and with that conclude saying that you are there to support her. And any specific question she asks, like should I be terminating, should I be continuing, what would you do if you are me, We need to tell her that there is no one-size-fits-all approach. My role is to explain the options, risks, and benefits so that you can take a well-informed decision. I know this has been a lot to discuss. I'll be offering you written information of what to expect when you have pregnancy following the diagnosis of breast cancer. So book an appointment and document all the discussion you have had, and get back with the MDT team who is going to plan for the chemotherapy at the earliest. So remember the 4 pillars of communication for the station: the empathy, communication, shared decision making, and patient safety. Master those 4 elements and you'll be able to perform strongly in the station. Wishing you best of luck. Dr. Meera Kumar, thank you for watching. Follow for more. Bye bye.